So I had a few requests to do a little bit of a review regarding the heart for cardiology. So I'm just going to run through the anatomy of the heart really quick, as well as the electrical system, so that hopefully there's a little better understanding and we can all move forward well together. So, the heart. Obviously sits in your chest, left side, most people. The heart, the myocardium, all these little like hardcore muscular cells here, they generate their own electric, okay? In order to keep you alive, right? Because your heartbeat is really what's keeping the blood flowing around your body. So if you start in regards to the blood flow from the heart, let's start at the right atrium. The right atrium receives blood from the head, from the superior vena cava, and from the rest of the body, from the inferior vena cava. Okay. Once the blood collects here in the right atrium, it stretches that muscle so that it can contract against it, sort of like when you stretch a rubber band. When it gets to the certain point where it's full and it's the right part of the electrical rhythm of the heart, the atrium will contract and push blood through the tricuspid valve right here. Remember, tricuspid has an R. Okay, an R in it, versus mitral, which I know also has an R, but it has an L. To help you remember what side of the heart they're both on. So blood flows out of the right atrium through the tricuspid valve into the right ventricle. Now, even if you look in this picture, the left ventricle is much larger and much more muscular than the right ventricle. Okay, so the right ventricle doesn't have to pump blood very far. It only has to pump blood through the pulmonary artery to both lungs. Here's a sad looking lung. Here's another sad looking lung over here, okay? It's a very small circuit, so it doesn't require a lot of muscle to move the blood. So the right ventricle is filled with blood from the atrium. It stretches. Blood now comes back up, flows through the pulmonary valve, up through the pulmonary artery, and then splits between the left lung and the right lung. After the blood goes through the lungs, right, circles through the lungs, picks up all that oxygen, it comes back to the left atrium through the pulmonary veins. Remember, arteries are away from the heart, and valves and veins are towards the heart. So now you have the oxygenated blood that's coming back to the heart into the left atrium here. Let's change colors. Now we have oxygenated blood, right? So we've got oxygenated blood here in the left atrium. It's coming back from the lungs, passes through that mitral valve that we talked about, right? Mitral has an L in it, so it's on the left side of the heart, into this extremely muscular left ventricle. Okay, so the left ventricle has to pump to the entire body, so that's why it's so muscular and it does such a good job. Okay, it's really the workhorse of the heart. After the left ventricle is stretched due to the Frank-Starling principle, it has a powerful contraction and it sends the blood through the aortic valve. Okay, remember that's pretty easy to remember, through the aortic valve, up through the aorta. Okay. As the blood comes up and around, it splits to the head. It splits to the subclavian arteries, right, for both of your arms. On this side here, arms. And then it goes down to the body, okay? So let's do a little erasing real quick because there's something kind of cool. So The interesting part is the opening to the coronary arteries is like kind of back here, underneath. I'm not sure which side it's on, but it's underneath the aortic valve. So if you think about it, as the left ventricle contracts, it opens the aortic valve. As the aortic valve, which you can kind of see here, let's see if I can make it a little greener, right? The aortic valve is right here. As it's forced open, it covers the opening to the coronary arteries. Okay. After the while the left ventricle is being filled, which is during diastole, the aortic valve is closed, which means that the blood can now kind of backflow and enter into the coronary arteries, and that's when the arteries in the heart receive blood. So if you have a blood pressure of 120/80, the coronary arteries are getting their blood at a pressure of 80. Okay, like the diastole part of the filling. Another couple things that you need to know. There's two things we call preload and afterload. So preload is the amount of blood that fills the ventricles. And usually the amount of blood that fills the ventricles is also, usually correlated to the amount of blood that fills the atrium, right? So if you are in a cardiac dysrhythmia such as AFib, where you lose part of that atrial kick, right? That coordination between the top part of the heart and the bottom part of the heart, the lub-dub. If you lose that, you might lose some of the preload because you're not getting as much blood into the ventricles, right? The preload is the amount of blood that's filling and stretching the ventricles for the cardiac output, okay? Now, afterload, here we'll talk probably about afterload a lot. Afterload is important in so much as like a lot of disease processes deal with afterload, right? So acute pulmonary edema, there is a sudden change in afterload. Now, afterload is let me put it in a better color. That's not a better color. Afterload is the pressure in the body that the left ventricle has to push against. Okay? So, when we give a medication like norepinephrine, where it constricts all of the blood vessels in the periphery, that's increasing the afterload. Okay? If you have a disease process such as anaphylaxis, where it dilates all of the blood vessels, that's going to plummet the afterload. Okay, so if you have, you want to kind of be within like this narrow range between not too much afterload and not too little afterload. Okay, so if it's in that good range, you have a good blood pressure, your system's working fine. Once you have a derangement that really kind of screws with either the preload, the afterload, or both, then that's when you start to really run into shock states or acute pulmonary edema and a lot of other issues. So that's your basic anatomy side for review. Now, the electrical system. You have your SA node, lives up here. That's not bright enough. Your SA node lives up here, okay, in the right ventricle, in the right atrium, sorry. This is your main pacemaker of the heart. SA node usually pumps at 60, or it releases an impulse at a rate of 60 to 100 beats a minute, okay? When it does that, right, because it's the main pacemaker, it releases this impulse down these pathways. Now, if you look at these pathways as the express lane, okay, there's nothing impeding the flow of the electric. It's moving very rapidly, and it gets to where it needs to be. So the electric goes from the SA node It goes down into the different tracts within the atria. We call that the intranodal pathways. You don't intraatrial pathways. You don't need to know the specific names of the bundles or anything like that. And it depolarizes the atria. Okay, depolarization is that change in electric that you need to understand that concept. So when that electric changes, it stimulates all of the different cells in the atria, giving them the signal to contract. Now, you can have proper electrical function without a proper mechanical response. This can be seen in instances such as pericardial tamponade, right? The heart is being crushed by blood in the pericardium, right, all around it. So if you have all of this pressure around the heart and it cannot contract, then you'll have beautiful electric pathways, but you won't have any muscular contraction, which you'll see a nice EKG, but you won't necessarily be feeling an appropriate pulse. Now, as the heart depolarizes, there's a slight delay between depolarization and the actual mechanical function. But when you're looking at the EKG, the depolarization of the atria, up here on top, right here, we're going to just kind of highlight that, is associated with the P wave. Okay? When the heart's still, right, the moment in between pulses or pulse beats that you feel in the wrist, you are at this isoelectric line. And then you hit the P wave, which is a depolarization of the atria. So the atria are depolarized, the electricity continues on its pathway, and it gets to the AV node. Okay, so the AV node here is the gatekeeper to the ventricles. It makes sure that if the atria decide to kind of lose their bananas, that the ventricles, which are really the most important part of the heart in terms of moving blood around, they make sure that the ventricles are not overstimulated. Because if the ventricles are overstimulated, they can't pump effectively, and you end up with a cardiac arrest state, or you end up with a tachycardia that's not adequate to sustain life. Okay? So in that little moment right there, we get different color, you have this pause, okay? This is the pause at the AV node, okay? And that's totally normal. It should be a brief pause before the electric continues on down right here, which would be called the bundle of His. Put that in right here. The bundle of His. And then it goes to the right bundle branch and the left bundle branch, okay? So as the electric moves down, it goes down the bundles and it gets to the Purkinje fibers right here, okay? These little kind of horsetail looking vibes here. Those are your Purkinje fibers. They make sure that they wrap around the entire heart and make sure that all of the different muscle cells are stimulated. So as the electric moves down, oh, I need a different color. As the electric moves down the conduction pathways, okay, it gives you your QRS. So sometimes you have a little bump here and it goes up, down, and then comes back to your isoelectric line, okay? And that's your depolarization of your ventricles. So as the ventricles depolarize, the muscle contracts, and then as the electric now repolarizes in the heart, let's try white. So as it comes back the other direction and repolarizes, and that gives you your T wave. Okay? That's the T wave is repolarization, okay? So while every other part of your EKG is equivalent to depolarization, the T wave is the only part that is equivalent with repolarization. And that comes right back down to the isoelectric line. Let me make that a little cleaner. You come right back down to the isoelectric line and you start the process all over again. Now, the P wave should be particularly symmetrical. Okay, it should look kind of like a cute little bump. QRS is going to have different morphologies depending on various views of the heart or if there's any sort of underlying issue. And the T wave should be asymmetrical. Okay, so it should have this kind of like rapid, hold on, I'm having a drawing moment. It should have a rapid upswing followed by kind of a lazy slope down. Okay, so if you kind of look at it, right, you have the one side that does this and the other side does like that. It shouldn't look like a P wave. It shouldn't be symmetrical. Symmetrical T waves are usually indicative of an issue. So going back to the rest of your heart, if for some reason something happens and your SA node is no longer functioning, the AV node, right here, have that path right here, has an intrinsic rate of 40 to 60. Okay, it's your backup mechanism to make sure that you don't die if something happens to your SA node. Could be a number of different things that cause your SA node to not function appropriately. Could be drug related, like medications. It could be ischemia related, hypoxia related, any number of things. So your AV node will take over if everything above it fails to work, right? Because all these little atrial cells will also potentially try to take over as well, until they're overridden by the AV node. Now, if the AV node fails to work, then all you're left with are the cells of the bundle of His and the Purkinje fibers, right? Everything below. Everything that's down here below, that's horrible, has an intrinsic rate of 20 to 40. Okay? And you'll see that there's like a certain level of overlap in the rates, in the intrinsic rates. Okay? Your body wants to make sure that you survive, so it's going to do everything in its power to do so. If for some reason you have some sort of issue, let me clean this up a little bit, in the conduction pathway, and there is a blockage, it's usually caused due to ischemia or something like that, right? So say, for example, you had a small heart attack at some point, and now the right bundle branch is cut off because it was damaged right here, so the signal can't get through. The cells of the heart are really interesting. They're interconnected, so they form kind of like this that's a terrible picture, kind of like this chainmail of muscle, okay? And the thing is, if one cell is stimulated, the next one will be stimulated. It's kind of like when you do the wave in a stadium, right? So if this one ends up being stimulated, it will pass the message on to the next one, which will then pass that on to the next one, and so forth. So once the electrical signal gets to here in the heart, and it can't go any further, it will start to go cell to cell to cell to cell and send the message to depolarize in that direction, okay? Or in that manner, where it's very slow, kind of tag your it, move the impulse along to the next guy. Meanwhile, this is going to continue on the way it's expected, so you'll have a very fast response of the left ventricle while you have a slower response of the right ventricle, and vice versa if there's a left bundle branch where this pathway is damaged. So when that happens, you end up with what we kind of just call as a bizarre looking QRS. So it's very wide because the time that it takes for the electrical impulse to make from one cell to the next just broadens it out. Think of it as like extending your travel through time. So you'll end up with maybe like a really funky looking EKG like that, where the QRS is really broad, and the T wave is in the opposite direction. Or you might end up with a QRS, so here's your P wave, right, going into it, and then you end up with a one that looks like this. and then a T wave, right? We call that the bunny ears, okay? But that's usually the bunny ears kind of notched looking QRS is indicative of a right bundle branch block. And this is usually indicative of a left. No, that's about it. So I hope that helps.